Hi, everybody. This is just a catch-up of the second ECG lecture that we gave. I'm just going to put it up now. It's not going to be a long one. Most of you should have seen the first one by now. So in this case, what we're going to do is that we are just going to quickly go through to give you an example of ECG and your approach to these particular patients. Okay, so let me just start from there. Slideshow going over there. All right, good. So let's have a look and see. So as with all our ECGs, you remember we analyze axis first. We then analyze rhythm, following those particular parameters that we've got, looking at P-wave morphology, P-wave presence, absence, PR interval, QRS width, QRS following Ps, regular groupings. Then we analyze rate, and then we analyze zone. So here we have a 54-year-old woman complains of mid-sternal chest pain and lightheadedness. All right, so immediately our mind should be going towards an ischemia of some point. And those of you who have some experience with ECGs should already be seeing something, but we're going to do it in a step-by-step fashion. My apologies, my voice is not too good. My throat is just troubling a little bit, but I'll try as best I can. So let's first look at the axis. So the axis that we have, if you remember, we look at lead 1 and we look at lead AVF. So in this case, what we have is a upward pointing lead 1, which implies that we've either got a normal axis, we've got a left-sided axis. And if we come through to AVF, AVF is more, or is predominantly negative. So because it's predominantly negative, we are going to say that this is more of a left-sided axis. If you want to be 100% sure of where the axis is, you would look at the most biphasic one, which in this case would come out to AVF as well, although predominantly more negative. So we, because it's predominantly more negative, we assume that it's not absolutely perpendicular. Now remember, this is just a simplified way that I'm giving you guys. It's a lot more important. So with the AVF running across, and now tilting away. So majority of it is tilting away. So we assume that it's starting to go into the left-hand side. To work out exact degrees is a bit more complex, but I don't want to get into that because in our case as emergency, casualty, OPD doctors, that doesn't make much of a difference to us. It's for those cardiologists earning 4,000 Rand per consultation. So let them sit and work out exact degrees. We need to get our patients in and out. So we know that we've got a left-sided, going towards the left-sided axis, all right? Within normal though. However, it's still within normal, but it's a left-sided axis. Now let's look at our rhythm in this case. So let's start with the P waves and let's look for where we can see P waves that are more or less normal. So the best one that we can see is in lead 1, all right? So this implies that the atrial axis is actually towards the left-hand side. So the atrial axis should actually be a little bit more anterior. So it tells us something's going on, all right? But we'll get into atrial abnormalities much later. So we've got these little P waves, they are present. Let's look at the distance between the P and the R. So if we start there from P, we've got just about 1 1/4. So less than 0.08 milliseconds. So this is a short, PR interval. All right, now we'll get into the reasons for short PR intervals. Most of them are due to conduction abnormalities. So the conduction abnormalities that are the most common or that we normally see are re-entry excitement syndrome. So things you may have heard like Wolff-Parkinson's White, LGL, but those are tachycardia. So we already discount those. So the other reason that you get these PR intervals that look like that are actually what we call junctional rhythms. And junctional rhythms most commonly have an absent P wave or very shallow P wave. Junction means that between the atrium and the ventricle, you have an alternate pacemaker cell. Now, the reason that we need to worry about this and why we're going to stop here for a second is because normally it's your SA node that's higher up that is actually providing the impetus to the AV node. And in this case, it's not there. We don't have a normal P wave and the PR interval is very short. So that tells us that this is actually coming from lower down. So we start thinking about ischemia already, vagal nerve damage, things like that. Why is this SA node not talking to the ventricle? However, the ventricle is receiving a signal from higher up, so it knows what to do. I always give the guys the simplified example of narrow and wide QRS complexes. If you were working in my department, here I stand, Dr. Mohammed, head of department, working in emergency department for a few years. You're a student, you're a new doctor or a ComServe doctor. We get a patient with an ECG. I'm the SA node or the junction or whatever it may be, and you are the AV node and the rest of the ventricle. Basically, what happens is as soon as that ECG comes in, I have a look and I tell you it's a pulmonary embolus. Do A, B, C, and D. So what I've done is I've given you instruction. So because of that instruction, you know what to do. If I wasn't there, you would probably still reach the same conclusions, but it might just take you a little bit longer. Now, that's a simplified way to talk about the pathophysiology, but it's very common. It's very similar to what actually happens. Essentially, the AV node is kind of sitting over there and always looking up. It's got one eye up looking at the SA node. So the SA node tells it to beat, it beats, and it knows exactly what it needs to do because it's following a natural rhythm. With the junction, a similar problem. It's looking up, just that the junction's a bit closer. Let's say the SA node is somewhere up there, junction's a bit closer. So it can see it very quickly. So it still gives you a narrow QRS complex. And if the junction is extremely close, then you actually don't see the P waves. And if the junctional, excuse me, electrical signal is very small, then you don't see the P waves. So that's why we see narrow QRS complexes here. So we do have P waves. They're a bit shallow. They have given us narrow QRS complexes. If we go down to our rhythm strip, we can see that the QRS complex does follow every P. So that's quite good. And we can see that the PQRS complexes are quite, what you call it, regular. There's a bit of sinus arrhythmia, but not much. All right. So from our rhythm already, we know we've got a possible AV junctional rhythm, or like I say, a re-entry circuit. But the re-entry circuits will give you tachyes. This doesn't mean AV junctions don't give you tachyes. But because this particular one doesn't have a tachy, we assume it's just a normal AV junctional rhythm. And we say that we've got to worry about ischemia, given the history and already what we're seeing over here. But besides that, our rhythm is okay. Let's look at our rate. So again, like I say, I'm going to do the work that the ECG normally does for itself. 2, 3, 4, 5, 6. 300 divided by 6 is 50. So we've got a mild brady that's going on over here. So we've got a little bradycardia, but it's not a sinus brady, but anyway, that's a bit intricate. I don't want to get too involved. The more important thing that I want to cover, and what my intention was when we did this lecture initially, was actually to look at the different zones. So I'm going to cover the different zones, and we're going to look at what we see. Now, I'll take you through the pattern that I normally follow. So we've got leads 2, 3, and AVF that make up the inferior portion of the heart. Those three leads, basically, lead 2 sits there, lead 3 sits there, and lead AVF, sorry, I'm going to just bring it down. Lead 2 there, sorry, lead AVF there, and lead 3 there. So those three are essentially looking at the heart from the bottom end, right? What's the first thing that we notice? We notice these little ST depressions, okay? And they're quite widespread. Even in lead 2, you can see a little ST depression. Now, we haven't reached a conclusion. We've just noted that we've got ST depression. Now, if you were to stop there, you would say this is a non-ST elevation MI. So that's why I say we're continuing on. The next thing that we look at is we look at V1 and V2. I'm just going to move this a little bit, sorry. So if you look at leads V1 and we look at leads V2, what do we notice? We notice the normal Q wave morphology that we normally find in V1. We see a very slight, elevation in V1, very, very slight. However, once we come to the rest of the septum, so remember V1 and V2 look at the septum, we see quite a high uptake over there. So that's your QRS complex. This is your ST segment, and this is your T wave. So we worried about this little part here. And you can see it's raised by 1, 2, 3, 4, 5, 6, 7, nearly 8 little blocks above the isoelectric line. Let's come to the anterior one. So the anterior leads V3, V4. We see that we've got a 1, 2, 3, 4. Here we've got a 1, 2, 3. So we can see where most of the damage is taking place. We come across to V5 and V6, which are the lateral leads. We don't see too much over there. Then once we come across to the high lateral leads, so remember leads 1 and AVL essentially are looking at there and there. So they're looking at the heart from a much higher aspect then V5 and V6, and we can see these massive ST elevations again. All right. So if you were now working in your emergency department, you would describe your myocardial infarct, because this is a myocardial infarct based on the areas that are involved. So this is an anterior infarct combined with a high lateral infarct. Okay, so those are the two parts of the heart that are involved. So this is the left anterior descending artery, and it's the majority of the blood supply is actually going towards this area. So this means this is a massive infarct. So we would again stratify our patient now as high risk. Just to get back, the reason why we have the ST depressions, these are reciprocal changes. So I'll explain reciprocal changes again. I am let's take for this example, I am lead 3, and you as the viewer are V2. All right. So when ischemia happens, all right, when this ischemic pattern basically takes place in the heart, the ischemia damages that part of the cell membrane so that the cell membrane is unable to cause its normal repolarization and depolarization. So because there's damage, repolarization tends to start much earlier than what it would normally happen in a healthy heart. Okay. Oh, and actually, I've done a big mistake that I always advise guys not to do, and that's to look at your right lead as well. And we can see a little drop in AVR. So my apologies. We are all fallible. I'll personally give each of you 25 cents. Just send me your account details to make up for that. So as I was saying, so the worse the ischemic damage, the higher the ST elevations, but we'll get back to that. So like I say, you as the viewer now are lead V2, all right? I am lead 3, all right? So V2 is there, all right? Lead 2 is there, and lead V3 is at the bottom over here. Sorry, lead 3 is at the bottom over here. So we are essentially looking at the hearts from the opposite point of view. So you are sitting opposite to me now, and you are lead V2. So what happens is the heart depolarizes, right? But because of damage, it tends to repolarize very quickly. So again, that repolarization happens, and that ST elevation happens very quickly. So you notice that everything's coming towards you. So you as V2 mark it as an elevation. Myself, on the other hand, when this happens, I see it moving away from me. So I see a depression. So in simple words, leads that are on opposite sides see opposite things, or they should, especially in the case of ischemia. If they don't see opposite things, then it changes your diagnosis, which we talk about in other lectures. So just for simple ischemia, look for ST elevations and look for ST depressions. There are differentials for when you only have ST elevations, all right? We'll get into that in other lectures, but in this particular one, we now have an anteroseptal actually, because V2 also looks at the septum, and a high lateral myocardial infarct. Now, the thing is, if you want to know how bad your patient is, look at how many blocks are involved. Now, there are strict criteria to actually, and in fact, physicians and cardiologists have strict rules. If your accumulative blocks are so much, you're getting to this point, you're getting to that point, it guides them on ICU management. But remember, we're not too worried about ICU management, we're worried about emergency management. But this should already tell you that quite a bit of the heart is involved, and it's involved quite badly. So in other words, this is not the type of patient to do your ECG on, you then go out, have a cigarette, come back, chat with everybody, and then continue. No, this patient needs your full and undivided attention, right? So this patient needs regular ECGs, at least 10 to 15 to 20 minutes, or even half an hour apart, to see if there are any dynamic changes, if it's getting worse, things like that. Right, so we've diagnosed our ECG. We know it's an infarct. What do we do? So just quick management. In an emergency department, keep oxygen levels above 94%. The reason being, you have a damaged heart that needs oxygen. Keep your oxygen concentration as high as possible so that the amount of oxygen getting to that damaged heart is maximized, right? So whatever's left over basically can still function properly. You want to give morphine. Once you've got a confirmed MI, I normally advise the guys to give at least 5 milligrams of morphine. In this particular case, when you've got an anterolateral, and we'll talk about right-sided on another step, but when you've got anterolateral, give TNT. The vasodilation, excuse me, excuse me, the vasodilation helps to relieve symptoms, and if the plaque is not too tight, can actually allow blood flow down to the ischemic area, but it doesn't happen very often. The only time you need to be scared of TNT is if you've already got a hypotensive patient. Don't give TNT, you'll drop their BPs even more. So you're given half an aspirin, you're given morphine, you're given TNT, you are now watching the patient, you're trying not to overload them with fluids. You want to just try and keep them stable for now. Now, ideally, your door to needle time, that means the time from when you have diagnosed this to when the patient should receive thrombolytics, is about 30 minutes. Okay, so you would alert everybody that would come through. In reality, it doesn't often happen so good. Time to need, yeah. And then if you work in a big center and you have access to a cath lab with angiograms, then you could say even 90 minutes. All right. But in our settings, rural, semi-rural, we would actually start with thrombolytics, alteplase and things like that. But that's for the physicians to decide. And if you're working in one of the other hospitals like Dundee, Denhauser, places like that, you would transfer as quickly as possible. TNT, morphine, and with morphine, you'd go up to 10 milligrams maximum. You wouldn't really go beyond that. Too much TNT would also drop your BPs too much, and overloading the patient with fluid would also cause a problem. Right? There's no, I mean, it's management of myocardial infarcts is a huge topic. I can't cover all of it now, but just so that you can recognize it. The truth is that if you don't recognize it, you can't even do anything about it. So hopefully now you'll be able to recognize it a bit better. Okay, so we've looked at everything. This is what our assessment of the ECG is. Okay, so let's see what's the answer that they give us. All right, so we've got an AV junctional rhythm, like I say, rate of 50, acute anterior and high lateral myocardial infarct. P waves are present with short PR interval, 0.12, just depending on how closely you look at it. Suggestion of an AV junctional origin of the beats. The rate is typical of an AV junctional origin, although I must be honest, depending on the orientation of the heart, you can get absent P waves with narrow complex, in which case it also becomes AV junctional. So don't get scared by AV junctional. AV junctional just means atrioventricular junction. That little piece of tissue that sits between the atrium and the ventricle has auxiliary pacemaker cells that take over from the sinoatrial node. All right. ST segment elevation is present in mid-precordial leads, leading to the diagnosis of anterior wall infarct, V2, V3, V4. Remember, V2 is called anteroseptal. It looks at the septum and anterior. ST segment elevation is also present in leads 1 and AVL, corresponding to the high left lateral wall of the ventricle. Reciprocal ST depression is present in inferior leads. The presence of reciprocal changes significantly increases the specificity of ST segment elevation for acute MI. And in our setting, that's as far as we take it. There are other causes. There's actually multiple causes for reciprocal changes, not just MIs, but these are very rare and it's not something you can diagnose initially. It's after echo, it's after angiography. There's a lot of things, so we don't even worry about those. So I hope you guys understand that. If you guys haven't, have a look at the algorithm for ACS management. And in your area, I would suggest that you put it up. What I'm going to do for a second, just while we are going through, let me just see if I can get up the algorithm quickly. I'm going to try and put it on the screen just so that you guys can see exactly what it is, So let me just get that on computer. Ischemia algorithm. Hey, I actually did it correctly. No, not ischemic stroke. Let's just see. Acute coronary syndromes algorithm. There we go. So I'm going to give that to you now. Just try and find it over here. Sorry. Okay. Right. I just want to see that I've got the right one over here because there are a few. I just want to make sure I haven't given you the incorrect one. What I would suggest is that you guys do take this, stick it up in your areas wherever you are, I think this is the closest one that I've got right now. Just to see what's going on. I just want to share the screen with you in a second, just so that you can see. Okay, no, that's the incorrect one. Let me rather put it up on a, let me just save it and then we can put it as a full screen. Just put it to desktop, right, there we go. It is a bit of an older one. I think there is a newer one now, but anyway, we can have a look at it and see. I'm just going to try and get out of all of this. Okay, right, yep, I've got it over there. So just open it up and then I'll share that screen with you and then we'll just go with that. All right, let's get this a bit larger. All right, unfortunately, I don't have a pointer on here. Let me just move myself out from here. Okay, so this little thing you can screenshot and I will actually post it on the group as well, just so that you can have a look. So it gives you a basic idea of what you should do. Now, this one here is actually, this is not as comprehensive as I would have liked. What I'll do is on the group, let me give you the one that's a little bit more comprehensive than this, and hopefully that will give you an idea. But my advice would be to please put it up somewhere where you know that it can help, right? This is a simplified one. There's one that's a little bit more detailed. So I'm going to put that one up. Okay, guys, I hope everything was okay and you guys learned a little bit today. And what we'll do is that I'll post another one. My apologies if the voice is a bit not 100%, but I'll try and post again. Thanks, bye.